We good?
All right, everyone, welcome to the ASCO GU 23 bladder cancer poster walk.
Yes.
Poster jog.
Jog, yeah.
We're going to do a few posters.
Yes.
We're going to start with some SG ones.
Okay, so Scarcity govitecan, an antibody drug conjugate targeting TROP2 SN38 payload, 113 patients here. So this is the largest cohort we've seen. I think it's important because it's more robust data. Response rates of 32%, which actually is respectable. Remember, EV is single agent in the same setting, probably about 40%. PFS of 5 months, and OS of 11 months. Cross-trial comparisons not really very valuable, but there's activity.
Yeah.
The drugs in a randomized phase 3 study, TROPiCS-4, and that's chemotherapy versus single-agent SG in platinum refractory disease. I think that's relevant. 2 bits of toxicity. Firstly, hematological toxicity. GCSF, I think, is important here. And the second piece is it's causing some diarrhea as well. And there's the I pointed in the wrong piece. I apologize for that.
Good.
Okay, we're going to keep going because we're going to go to the combination. We're going to go to the combination. Okay, you with me?
I'm with you.
So this is the combination of pembrolizumab with sacituzumab govitecan, and this is cool because it's the combination. Remember, there's EV pembro combination. Response rates of 73%. This is different because it's in platinum refractory disease, not frontline cisplatin ineligible. Nevertheless, I think it's entirely reasonable to say what were we looking at? 42%. Response rates maybe not quite as impressive as we've seen. And here durability, only 5-month PFS and OS of 12 months. I think EV pembro data probably even here you'd say looks better, although the cross-trial comparisons are really complicated. Is this worth taking forward to randomized phase 3 off this data as we see it? I think it's touch and go, to be honest. And the reason why that's the case, well, we haven't seen a randomized phase 3 announced. So I think this is promising, but maybe we need to look at triplets or different approaches because I don't know. I think EV pembro might be a little bit better.
Seems like it.
But why don't you come with me? Why don't you come with me? We're going to go here. We're going to go here. I think this is cool. So I'm not going to talk too much about this. This is data from Memorial, Jonathan Rosenberg's group. And what I really like about this, upper tract urothelial cancer, neoadjuvant ipi-nivo. And look, here we have got 6 patients, 67% achieve, essentially down staging. I know this is a difficult, of course it's a difficult population. You might know from the adjuvant trials, it doesn't look like immune checkpoint inhibitors work that well in upper tract disease, and maybe if he makes a difference. I think they're going to continue with this trial. I think it's terrific. We're going to keep going, Brian. We're going to keep going. We're all the way up here.
Viewers are getting an insight into what most of my day is like following Tom around.
Oh. We've gone too far, Brian. We've gone too far. Where are the?
We've wandered into prostate cancer. Sorry, it's for another show.
Oh yes, it's here. Apologies. Right, this way. This is very embarrassing.
This is a good one.
This is good. This is good. So we're going to start here because it's easier.
Got it.
This is BCG refractory CIS. Now you might be aware that pembrolizumab, you will be aware that pembrolizumab is approved in this space. This is BCG refractory disease. The patient is supposed to have cystectomy. And you'll remember that we're looking at systemic therapy with pembrolizumab licensed in this space. I don't think it's given that much. This is for patients who have FGFR alterations. So tissue tested FGFR alterations and then erdafitinib at 6 milligrams. And you can see here, look at all the responses. Now the follow-up's not very short, and there's the CR's defined as regular cystoscopy without relapse, but no one has relapsed yet. Now it's a bit premature, but you'll be remembered that about half the patients relapsing in about a year with pembro. And
this was the CIS cohort.
Yeah, this is the CIS cohort. This cohort, come with me. This cohort is quite cool. And the reason this is cool is, so what they've done here is this is in patients with papillary disease, and they go in, they take some of the tumor out, they test it for FGFR, and they leave some of the rest of the tumor behind.
That's
yes,
brave.
We chatted about that. And I chatted about that, and I think that ethically it's doable. And you know why it's doable? Because look, the CR rate is really high. The tumors are sort of disappearing in this population. There appears to be real activity, and I think this is really cool.
Did they say what the percent that had FGF was? Did they give you the screening?
They didn't.
How many were screened?
We probably can find it. I
patients?
didn't ask that question. It's a really good one, Brian. We're going to come back to it because there's no time. There's no time. There's no time. Don't ask difficult questions. Over here. Over here. Now, I like this, and the reason I like this
Won a merit award.
is, well, that's not the only reason I like
No, I
it,
know.
although I think it's terrific.
Pointing it out.
And this is Rafi's work. Petros is involved. Again, not why I like it.
Despite that.
Yeah. But here we've got the patient characteristics of a big cohort of patients. Some have FGFR alterations, and some don't.
And the premise is what? Why did they do this?
The premise is that we know that those patients that have FGFR alterations are thought to have a different immune profile. So your FGF3 alteration, you're thought to be more of a luminal cancer, an immune desert.
Less immune responsive.
Thought to be, and therefore less immune responsive.
Yep.
And so therefore people are saying, well, if you've got FGF alterations, you should go straight from chemotherapy to FGF, not to immune therapy. And what we see here is actually something I think a bit different from that, because what you can see is the overall survival for those patients with FGF alterations doesn't seem to be any different, whether or not they had the alteration or not. And that the PFS, people say is a bit different, but I'm not sure convinced by that.
Okay.
Personally, and I realise this is a big conclusion, which I'm disagreeing with, although it did win a merit award, so I feel slightly. But ultimately, the survival I think is really important.
Yeah, fair
and what
enough.
the survival tells us here is that if you have an FGF alteration, you should certainly be giving these patients immune therapy. You might want to sequence in FGFR first, and I can accept that, but immune therapy is a role to play.
Okay.
I've got one more if I may.
One more.
How long have I been going for? I won't
We're
get
at
lost
6
this time.
minutes.
Right, great.
See how long it takes us to find the next poster. You're getting into prostate.
Is it prostate already?
Yeah.
I think I'm going to go down here. Yes. Yeah, I love this.
Okay. Last one.
So this is Tyler, urine cell-free DNA. And essentially what this is doing, I think this is a neat piece of work. And what he's done is he's taken urine samples from patients and he's looked at he's measured allele frequency from urine DNA. And here is a non-cancerous cohort with low levels. This is a methylation signature.
Okay.
And you can see from here, this is a suspicion of new cancer. And here you're identifying with this urine test, this urine methylation test, using allele frequencies, you can identify patients who have a suspicious of cancer or suspicions of recurrence of cancer.
Yeah.
And while the data is pretty preliminary and quite early, this is a relatively easy test. It's a panel-based test. It's not a personalized test like Natera. It's from urine and not blood. And I think this is, for me, this is part of the future of non-muscle invasive bladder cancer. So we're going to be doing urine tests for this to see if we can clear, we'll be using therapy.
Kind of like urine cytology.
Yeah, but I think it's about, it's better
more sophisticated,
much
perhaps,
more, and much more specific and sensitive than urine cytology. So this was the last poster which I selected. There are some other things we could have done, but we are.
Thank you for your attention.